Thank you. My name is Andrew Schmidt, and it's a great pleasure to be with you here today. Just a little background on myself and the other speakers you'll see today. I received my undergraduate degree in toxicology from Clarkson University in New York in 1986. I received a master's degree in clinical psychology from the University of Texas at Tyler in 1994, and my doctorate in clinical psychology from UT Southwestern Medical Center in 2000. My primary area of expertise is in neuropsychology, and I've worked at various locations in Dallas and Tyler. I received training at Terrell State Hospital, Parkland Hospital, Sprague Hospital, UT Southwestern, and also the Dallas VA. I've had the opportunity to publish a lot in this area too, so I have numerous articles and book chapters in neuropsychology. I served as a professor in the Department of Psychology at UT Tyler from 2004 to 2017. And in 2018, I accepted a position as the director of neuropsychology right out here at UT Health Science Center. And now I'm serving as the psychology section chief. My two co-presenters today, they'll be doing the bulk of the presentation. They are two excellent pre-doctoral psychology interns that have worked alongside me this year. Candace is a licensed professional counselor with a master's degree in marriage and family therapy and in clinical psychology. She's working towards her doctorate in clinical psychology at the Florida School of Professional Psychology in Tampa, Florida. She's been working in the clinical field for over 16 years, providing therapeutic intervention services and assessment services to patients throughout the lifespan. She's presented several posters at national neuropsychology conferences, and her primary interest is in completing neurodevelopmental assessments with children and adolescents. She'll be completing her postdoctoral fellowship right here at UT Health Science Center in the child and adolescent track with us next year. Morgan Ferris Johnston is also a predoctoral intern, and her interest is in neuropsychology and neurodevelopmental disorders. She's completing her doctorate in psychology at Adler University in Chicago with a specialization in neuropsychology. Morgan also has an array of practicum and research experiences in several academic centers, including Loyola University Medical Center and Rush University Medical Center. She has a passion for pursuing prescription privileges and received her master's in clinical psychopharmacology in addition to her doctorate. Morgan prioritizes advocacy and leadership development and currently holds chair positions at the Illinois Psychological Association Graduate Student Section, the Illinois Association of Prescribing Psychologists, and Division 55 of the APA. Morgan is returning to Chicago, Illinois to pursue postdoctoral fellowship in pediatric neuropsychology and neurodevelopmental disorders. And I'm so glad they can join us here today. Just briefly, before we get to the slides, I wanted to talk a little bit about assessment and testing in general. I know that when I was in grade school, I had images of psychologists giving psychological tests, the Rorschach test or IQ tests, to determine someone's personality or intellectual capabilities. Later on, I thought that would be the determining factor, that just give this test and get this data. Later on, as a psychologist, got to know that testing is only measuring a behavior in a certain time, place, and context. That it's a lot broader. Doing an assessment is a lot broader than just doing particular tests. We learn test skills and we learn how to score and all that, but doing an assessment involves a whole lot more than that. We have to take that information from the testing environment and then extrapolate that to the external environment where they're living. We have to extrapolate that and make diagnoses, estimates, and recommendations of how things are going for them in the real world. And that's where the concept of assessment comes in. Tests are only useful if we understand it in that broad context of the person. So we can do tests, but what is equally informative is getting information from parents, family members, teachers, and also the behavioral observations we make. We also take a look at factors such as education, occupational status, home environment, medical conditions that also inform the meaning of the test scores. So although psychologists do in fact conduct tests, like I thought when I was a little boy, The test is only one piece of the comprehensive assessment, and we'll try to bring that into a brighter light as we go through the material today. Okay, with that introduction, Candace, do you want to get us started?
I will, thank you. So thank you, Dr. Smith, for that wonderful introduction, and I just wanted to thank everybody who is joining us. I know for most of you this is your lunch hour, so I appreciate you spending it with us. So for our learning objectives today, we're going to define psychological and neuropsychological assessment. We're going to discuss the purpose of evaluations, look at screening tools, also talk about referrals, as well as looking at kind of the overall outcomes that we hope for through assessment and evaluation. So what is psychological assessment? So basically it's when we're looking at having standard measures and we're looking at people's abilities in a lot of different areas. So as Dr. Schmidt was saying, assessment is not just testing. So we're going to be taking information from a variety of different people that are involved in these children's lives. And we're going to be testing a variety of different domains. We're going to be looking at their personality, just psychological pathology in general, as well as cognitive. So assessment can take place in many different settings. They can take place in an educational setting, a clinical setting, just with different organizations overall, as well as forensic. So typically psychologists are going to be the ones who are completing these assessments, and they last over several sessions in order to be able to get information from all of the different areas. So some of the common referrals that we'll see for psychodiagnostic assessment are kids that are suffering from trauma, experiencing anxiety, depression, inattention, helping us to really assess internal as well as external symptoms that are being observed, as well as academic and occupational functioning.
Regarding neuropsychological assessment, I want to be clear that there can be overlaps with psychodiagnostic assessment, such as looking at cognitive functioning, but neuropsychological assessment really is more nuanced, and I hope we can help identify that for everyone. So this is taken from the Cleveland Clinic. Neuropsychological testing is a specialty field that joins the medical fields of neurology, psychology, and psychiatry. An example of where neurology might come in with neuropsychological testing is if there's brain imaging, for example, traumatic brain injury or a bleed, and that can really help with the direction of testing. Neuropsychology involves determining how well the brain is working when it's disrupted. That could be an injury or a disorder. For kids, that might look like an injury that occurs at birth. And disorders could include neurodevelopmental disorders, which we are going to get into later in the presentation. Similar to psychodiagnostic testing or assessment, my apologies, a neuropsychological assessment is comprehensive and it includes a wide range of different functions. So many of the functions that we assess for in neuropsychological assessment are listed on the right there. Again, the number one point of general intellect tends to be covered in psychodiagnostic assessment as well. With language, we want to examine the individual's expressive language as well as their receptive language. We look at attention and concentration, processing speed, learning and memory, so that's how well an individual can take in new information, as well as their short-term and long-term memory. Executive functions, which can range from novel problem solving to their ability to plan and organize, visual spatial skills, and then motor speed and dexterity. So where do neurodevelopmental disorders fall? And this is important in the context of pediatrics specifically. So according to America's Children and the Environmental Report, Neurodevelopmental disorders are disabilities associated primarily with the functioning of the neurological system and brain. Examples of neurodevelopmental disorders in children can include ADHD, autism, specific learning disabilities, intellectual disability, cerebral palsy, and impairments in vision and hearing. These children with neurodevelopmental disorders can experience difficulties with language and speech, motor skills, behavior, memory, learning, and other neurological functions. When I think of the assessment that might be most appropriate for neurodevelopmental disorders, I would typically recommend neuropsychological testing for a baseline, and then psychodiagnostic testing may be used in later years.
So now we're going to go through some of the more common neurodevelopmental referrals that we tend to see. So starting with ADHD, I'm sure most everybody is very familiar with this. So this is going to be our kiddos who are struggling with hyperactivity, inattention, or both. Some of the things to keep in mind is with this diagnosis, it does need to be present in more than one setting. So when you have a parent and they're talking to you, also getting information about when these behaviors and symptoms are occurring as well as where. Gender differences to be aware of are boys are more likely to be diagnosed with hyperactive type. And they tend to show, more externalizing symptoms, so symptoms that are more easily observed. Girls, on the other hand, are more likely to be diagnosed with inattentive type because they tend to experience more internalizing symptoms. Important collaterals are to, of course, get information from their parents and what they're observing, as well as their teachers, to get an idea of how this is affecting them at school. Also, even talking with other adults involved in extracurricular activities, such as coaches or music teachers, things like that, that can be seeing these things. So the common terms and buzzwords to listen out for are really, anything related to them having difficulty focusing, paying attention, being very hyperactive, not being able to sit still, not being able to wait their turn, constantly interrupting others. Any of these things would be kind of indicators that there possibly is a struggle going on. So in terms of specific learning abilities, there are 3 types. They could have an impairment with reading, written expression, or in mathematics. So again, the best collaterals to get information from is their caregivers as well as their teachers. You're going to hear these parents and teachers talk about things like that they're not really just performing at the level of their peers. And there may be, spelling issues where they're leaving out certain sounds, difficulty sounding out words in general. So just phonics they're struggling with, reading comprehension where they're able to read, but yet if you ask them questions, they don't remember really anything that they were reading. So these are important buzzwords to keep in mind when gathering information.
Intellectual developmental disorder is another common referral that we see. A brief description would be that the onset occurs during the developmental period. To meet diagnosis or criteria for diagnosis, deficits need to be seen in both the individual's intellectual functioning and their adaptive functioning. A profile for IDD would tend to show deficits in intellectual functioning. However, different from our specific learning disorders, this might be more broad and across multiple areas. We see with a lot of children and adolescents that rather than having a strength or weakness, they tend to be showing impairments across the board. And again, following up deficits in adaptive functioning are crucial to meet diagnosis. So that might look like communication, and more importantly, functional communication. So being able to ask for things that they need, identify what they need, picking up on social cues and social participation, and then really these independent skills. Similar to the other disorders that Candace described, we want important collaterals. This can come from caregivers. That's important for those, complex daily living skills, teachers, as well as physicians. Some key terms or buzzwords to be looking for with IDD: delayed or unachieved in developmental milestones. This might be late to walk, late to talk, things of that nature. Again, we're going to see these children falling behind in school, but it wouldn't be specific to one area. It would generally be difficulties across subjects or across their functioning in the school environment. They may have difficulty socializing with peers, and this can range depending on the severity of the IDD as well. And they're going to require support with complex daily living tasks. So hygiene, getting ready in the morning, those are some that we have parents look out for, as well as the functional communication. And autism spectrum disorder is the last one that we're going to go through for our frequent referrals. This is persistent deficits in social communication and social interaction. And like our other disorders, it's important to be looking for this in multiple contexts and in multiple environments. We see deficits in social emotion reciprocity. So they may be able to express themselves, but they don't typically reciprocate conversations, or that might be difficult for them. There may be nonverbal communicative behaviors, and they may have difficulty developing, maintaining, and understanding relationships. We look for restricted, repetitive patterns of behaviors or restricted specific interest or activity. Again, the important collaterals are caregivers, teachers, and physicians. And some key terms and buzzwords to look for with autism spectrum disorder: difficulty with transitions, if a child is showing, interest in an object and then not wanting to transition from that object or subject at all. Rigid or fixated interests. If you bring up their interest in an evaluation, you might see that they continue to perseverate on that topic. Repetitive motor movements. Sensory sensitivities, this could include food or clothing. Minimal eye contact. Not responding to their name. This might be apparent in the younger ASD children or more severe. And then difficulty making and maintaining friends. Important nuance I want to point out there is that they may be able to make friends, but maintaining friendships over time may be more difficult for an ASD child.
Okay, so now to just kind of look at what's the purpose of having assessments. And there can be several different reasons, but a lot of times when people are presenting, either coming into their doctor, complaining about certain symptoms or behaviors that are occurring, or, just the parents coming in to us and letting us know what's going on. A lot of times parents just kind of want to put a name to what they're seeing. And so that would be where we would be able to provide a diagnosis. And, some professions do provide diagnosis, right? We recognize that you don't have to go through a complete evaluation in order to get a diagnosis. However, the difference is just through assessment, like we've talked about earlier, is we are going to be gathering information from multiple sources. And using the data that we receive from testing in order to be able to come up with what we feel like is clinically most appropriate for that child. Also, if there's kind of a question of multiple diagnoses, through evaluation, we're able to kind of narrow it down to which one is the most appropriate. We also want to think about what are the benefits of receiving a diagnosis. So a lot of times, especially in school systems, children aren't going to be eligible for certain accommodations or services unless they have a diagnosis. So the evaluation is able to provide that for these families so the children can get what they need. Assessment also helps identify what the strengths and weaknesses are for the child, which again can help guide recommendation. Building upon those strengths that they show, and then also, recognizing what areas of weakness or challenges that they have so that we can tailor our recommendations to that purpose. So some common psychological tests there's a variety of different tests that we can use within these domains, but we're gonna look at kind of overall cognition, having assessments through achievement tests, looking at specific domains, which could be language, memory, motor. Also, the clinical interview. We're going to conduct a clinical interview with the parent, and depending on the child's age, we'll also do an interview with the child and adolescent themselves. Personality measures. We're also going to look at behavior questionnaires, screeners, and projective tests. So not that we use all of these in every assessment battery that we do, but these are all possibilities depending on what the referral question is and what we're looking to gain information about.
So in regards to screening tools, I know that we have a lot of providers on this call that aren't just psychologists, so we thought it would be important to discuss the role of screening tools and how that can be used in other settings or with other providers. Screening tools can be really helpful, particularly in a primary care setting, for determining if a referral for further evaluation, whether that be psychodiagnostic or neuropsychological, is needed. And again, kind of going off of that point, it shows what an appropriate referral placement may be. So again, if it's a more neurological, neuropsychological in nature, or perhaps more behavioral in nature. A screening tool can help both the caregiver and the provider in these settings have more objective data to go with some of the observations that they're seeing about the child or adolescent. However, there's some things I want to be mindful of with screening tools. So ensuring that the screening tool is appropriate for the population or the diagnosis in question. Is it able to be used on a certain age range? Does it look specifically at a diagnosis such as ADHD, or is it slightly more broad? With screening tools, it's important to be considering validity and reliability, just as in our more robust measures. There have been some screening tools that might over-capture a diagnosis or overinflate answers. So the examples that we're going to give tend to be more valid and reliable for that appropriate referral. We want to make sure that a screener is cost-effective, that it's going to be helpful for you in your practice, both in terms of the ease of use and the appropriateness. And again, especially for those on here who are MDs or work in other settings, we want to ensure that screeners have an ease of administration and scoring for other providers. Some screening tools that we're going to go over. So these on this slide are specific to ADHD and autism spectrum disorder. The Vanderbilt ADHD Diagnostic Rating Scale, I've seen some individuals at UT using this. This is about 45 questions in length. There's parent and teacher ratings, and the appropriate age range is 6 to 12 years of age. This one has been shown to have good validity and reliability for a screener, and I believe we'll be showing an example of what it looks like later in the PowerPoint. The Connors rating scale is similarly used for ADHD populations. This is a little bit more brief and also goes up to a later age range, so can be used through 18 years of age compared to the Vanderbilt. In regards to autism spectrum disorder, the MCHAT, or the Modified Checklist for Autism in Toddlers, has been found to be helpful. This is a 20-item checklist for caregivers specifically, and this one is for 16 to 30 months of age, so being mindful of when we're seeing those signs in young kids in infancy. Also, we have the Social Responsiveness Scale, and this is a caregiver report. This one goes higher up in age, so can be used up to 18 years of age.
So for intellectual disabilities, there's not as many screeners out there. One that we found that is used quite frequently is the Child and Adolescent Intellectual Disabilities Screening Questionnaire. It's a very short questionnaire, only 7 items, and it assesses children from 8 to 18 years of age. Ideally, these children are most likely going to be identified earlier than this because, they start school in that, kindergarten to first, second grade range. Their teachers are going to identify them fairly quickly that they are falling behind their peers. In terms of emotional and behavioral disorders, for depression, the Beck Depression Inventory is a quick one to be able to use. This is more for adolescents and adults. The GAD-7, again, starting at 13 for adolescents and over, which assesses anxiety. The BASC is one that we use frequently. This questionnaire can, assess all the way from age 2 all the way up to 21. This is a great one to be able to get very specific collateral information from both the parents as well as the teachers. And older children are able to give a self-report as well. And then child behavior checklist from 6 to 18. So really, as Morgan was talking about, a lot of times when we are meeting with parents and they're able to describe what they're noticing or experiencing from their child, sometimes when they're actually doing an assessment tool, it helps kind of trigger different things that they may not have thought about. Go ahead.
I'm sorry, Candace. And something I just want to elaborate on with the BASC is that one might not tend to be the best screener in a primary care setting, but that one does elaborate the most. So if we're looking for the most collateral or the most in-depth information, the BASC would be a great tool there.
Yeah, good point. And so this is just kind of an example of the Vanderbilt for teacher rating scale. So typically screeners are going to be shorter, just to kind of give an idea what the child is struggling with and if a referral is in order.
So again, we want to cater to everyone on this call and discuss complications that might be associated with chronic health conditions and how neuropsychological or psychodiagnostic assessment would be helpful in those situations. This is not a comprehensive list. This is just some examples of disorders or health complications in childhood that could have some cognitive or otherwise implications. So epilepsy, congenital heart disease, spina bifida, with childhood cancers, and we'll get into this in the next slide, but also being aware of how treatment for that can impact cognition, and then genetic disorders such as Down syndrome or cystic fibrosis. And so we wanted to highlight the cognitive deficits, or at times there might be cognitive profiles that are associated specifically with some of the health conditions that I outlined. And again, this is not a comprehensive list, but just a good tool to exemplify where neuropsychological assessment could be helpful. So if we're looking at epilepsy, cognitive deficits or the profile really vary based on the specific epilepsy syndrome. So I have an example there. If we're thinking of frontal lobe epilepsy, that might be associated with deficits such as mild intellectual difficulties and executive dysfunction, which really goes hand in hand with that frontal lobe placement. That also might be a good example of where neurology or imaging could be helpful with kind of helping us see that etiology of the frontal lobe. With cancer, we know that there's cancer-related cognitive dysfunction in about 1/3 of cancer survivors in the US. And this seems to be a little bit more broad. This can be characterized by a decline in a patient's full-scale IQ, and then as well as impairment in core domains such as attention, vigilance, working memory, executive function, processing speed, and visual motor integration. If we look at symptoms such as Down syndrome, a specific cognitive profile associated with Down syndrome can include having more pronounced and pronounced language, my apologies, and verbal memory challenges, but maybe having some strengths as well, such as nonverbal abilities and implicit memory skills. In regards to psychodiagnostic testing in these individuals, that might be helpful for secondary symptoms or outcomes such as anxiety or depression that could be secondary to experiencing these pediatric health conditions.
So other things to kind of be aware of is what their experience was prenatally as well as perinatal considerations to take. So, you know, again, we know that there are different expertise on this call. So anytime you're working with a child and you're hearing things, you know, when you're gathering history, that they had prenatal exposure to drugs and alcohol and tobacco. These things have been researched extensively that there is impacts through, you know, different domains of cognition, as well as preterm, and especially extremely preterm, which is 27 weeks or below, low birth weight too. And if the mother experienced specific illnesses while pregnant, specifically either, you know, within the torch domains, chickenpox, HIV, high blood pressure, all of these different experiences can affect a child going forward. So anytime we hear these things, it's important for these children to be able to come in and get tested, and then to be tested, you know, on a regular basis so that we can catch anything that is deficit. Early intervention is definitely the key for a lot of these kiddos. So the earlier they're able to have these things identified, the quicker that we're able to recommend and they're able to receive certain interventions to help minimize those risks. So making a good referral, a lot can kind of go into making a good referral overall. So when you're looking at making a referral, one thing you want to consider is kind of where you're getting the information from. Is it a reliable resource? Is it somebody that is around this child a lot and the information you're getting is, you know, dependable? So also the settings that the behaviors and symptoms are occurring in. Always kind of assessing and asking questions about where all the behaviors are occurring. And also looking at, so with kind of the main outcome of assessment is to have a diagnosis, kind of understanding what is that going to do? Is it going to benefit the child? Or are there possible cons involved with having a diagnosis? Also, when making a referral, it's kind of good to have a little bit of a summary, kind of what assessment looks like, so that the parents can kind of understand and make an informed decision about if they feel like this is what is best for their child. And the reason I bring that up is because when a family comes in for an assessment, it's not kind of a one-time, 1 hour meeting. It's kind of a commitment. So they have a clinical interview first, which is roughly an hour and a half. And then on 2 separate days, they will have testing, which is where we're actually doing the test and gathering a lot of that data. Then on a separate day, and testing can last 2 to 3 hours per session. And then on a separate day, once all the information is gathered and we've scored it and we've written it up, then we will have a feedback session. So testing and assessment in general is a large commitment. So making sure that they understand that and being able to explain the benefits that come with that, even though it is a commitment.
So we want to discuss outcomes that not only patients can expect, but also that the providers who are giving us the referrals can expect. It can be helpful for guiding treatment, as Candace has mentioned, so we want to hopefully answer your questions about expectations as well as provide answers for the patient and their families. So some of this was a review from earlier as well. An outcome to an evaluation, whether this is psychodiagnostic or neuropsychological in nature, is that there tends to be diagnoses at the end of the evaluation. In some cases, this might be a new diagnosis. And in other cases, this might be looking at, does this child or adolescent still meet criteria for that diagnosis? Or how have their symptoms fluctuated or changed over time, if at all? In some cases, we may provide a provisional diagnosis. This may be if symptoms are only seen in one setting, or if we want more evaluation, more assessment, or follow-up over time. And that tends to be less common, but could occur. Candace had mentioned earlier ruling out diagnoses or concerns. So a common example we might have is a patient with a traumatic history, and then also presenting with concerns of anxiety and inattention or hyperactivity. And so really kind of trying to figure out which one is more forefront and which one seems to be driving the other symptoms. Sometimes a child might meet diagnosis for all three, and sometimes a child, it tends to be one that's kind of impacting the others. We may use diagnoses by history. And an important thing we like to point out with diagnoses is the use of V codes. So some examples could be, confirmed or suspected abuse, academic or educational problems, but this really can help add to painting the picture of that child without giving another diagnosis. Pros of diagnoses can be getting the accommodations, but in this context, academic accommodations that are needed. So this might look like a 504 or an IEP plan in which specific diagnoses tend to be needed. And again, it kind of gives a name and an explanation to how a child is presenting. Once we have that, we don't treat a diagnosis, we treat symptoms. However, it helps give that clarity most times. Some cons that can come with the diagnosis is the possibility of over-identifying with a diagnosis, some stigmatization that can come with diagnoses, and worry that a diagnosis can follow that patient over time. And this isn't specific to diagnoses in particular, but we also want to look for strengths and weaknesses within a patient's profile. And this might look like, you know, a child does better with visual memory than verbal memory. And if we're looking for those accommodations at school, we can make those changes accordingly based on that. Recommendations are something that can be, are expected in an outcome with the assessment evaluation. And these expand across settings, so behavioral recommendations, potentially recommendations for the patient's medical team. At times we have recommendations for the child to go back to their psychiatrist to potentially change their medications or reassess their medications. I discussed this in the previous slide, but academic recommendations are something we discuss quite frequently. This isn't just an IEP or 504, but again, specifically catering to how that child seems to be learning best and interacting with their environment. We like to include parenting recommendations, which is an extension on therapy recommendations. So how can parents change their parenting at home? How can they structure the environment better for the child? And then we also like to recommend follow-up testing. This is important to see how symptoms progress over time. For example, IQ tends to not stabilize until about age 9. So if a child is getting tested earlier, we might want to see if there's differences in that profile. And then regarding feedback and collaboration, Candace had pointed out that there is a feedback session at the end of an evaluation, whether that's psychodiagnostic or whether that's neuropsychological. And we really encourage parents and even at times other providers to be involved in this process. That might be going to teachers before a feedback session for questions you have about a child's 504 IEP plan. That might include having a child's therapist be involved in feedback. That might include having multiple family members or multiple caregivers be present so they get a good understanding of what a feedback is and what their report results are. So we really encourage everyone to be involved in this process and feel free to ask questions. It is your report, it is your evaluation, and so we want families to have ownership in that. These are some of our references. I see we wrapped up a few minutes early, but we really encourage questions or interaction from everyone involved.
Thank you so much. Really appreciate the information. It was great. And I would also like to encourage those who are in attendance to bring some questions to these experts. This is an area that I think there are a lot of questions on, and I think that we've gotten a good foundation to better understand what's involved. And so my question, I'll start with a question. You talked about some of the screening tools. In a clinic setting with primary care, the extra time is certainly limited. So with those screening tools, is that something that MA staff, LVNs, that they could then give to the patients on behalf of that PCP? Or is there additional training for some of those that need to be done?
No, absolutely. Pretty much because it's the self-report, just kind of gathering the information, most of them can be given by a variety of different levels of people, because we are mindful of that, right? And that's why when we were talking about the assessment tools, recognizing tools that aren't going to take a long time to complete, as well as a long time to score. So kind of the shorter the better, as long as the information is pointed, to be able to determine if, because a lot of the questions were answered the way that they were, that an assessment referral should be, provided.
Yeah, can I also add to that? Thank you, Candace. Um, in terms of what assessment tools or measurements can be administered by different people, testing companies actually list the tests according to an A, B, or C designation. C being the highest level, oddly, where it's restricted to people with specialized training. But there are A instruments out there that fall under the A category, where those assessment instruments can require a little less training in psychological testing in general, and can be administered by, like you said, nurses, other staff. There are tests that certainly fall in that category. And I guess it's probably, most of my work is an adult assessment, so it probably depends on the age group you're looking at too. But there are certainly assessment tools that can be administered by people who are working directly that are not psychologists or neuropsychologists.
Great, thank you very much. I know in talking with the primary care providers that we serve through CPAN, that is a challenge in the clinical setting. The time is limited, and to be able to use their time wisely is important. We did have a question. What is the best assessment for BPD? Is it MMPI?
That's a great question. I'm not sure if we have enough time to answer that question. Now, borderline personality disorder is, as all practitioners know, a challenging disorder, both to work with and to diagnose. The MMPI is pretty good at identifying that. We also have the Personality Assessment Inventory, the PAI, at identifying that. We generally want to stay away from diagnosing children with borderline personality disorder, although we do see the traits. Really good clinical interview and collaborative information can be probably the most helpful. Candace, Morgan, would you like to comment on that as well?
I was going to point out the importance of a collateral in that case as well. I think BPD, if diagnosed, tends to need, more time, more length of time and exposure to the clients. That might be something more appropriate in outpatient therapy than a psychodiagnostic assessment. But if an assessment tool were to be used, I would use the MMPI. Candace, do you have anything to add?
No, the only thing I would add is just that I think that, especially with borderline personality disorder, this is one of those disorders that tends to have more stigma with it and can possibly be damaging, especially given to children or adolescents. And that's why it's more of a diagnosis that's going to be given later. And so that would be something to really take into consideration before just applying the diagnosis.
Great. Other questions? So I have another go ahead.
Just a quick one. You mentioned kind of what's involved in, the family commitment and getting assessments done. Is that the same for like an autism testing as well? Is that a several-day process?
Yes, definitely. Because we want to give a lot of time gathering as much information as we can and not just focusing on the testing in general, but that would be typical as well for ASD.
Gotcha. Well, we've recently gotten an ABA therapy place here in Nacogdoches, which we're so excited about, but they require an official diagnosis, not just from the pediatrician. And so finding those resources has kind of been a challenge lately. And I'm just curious what to expect. And then certainly getting those folks out of our town to those appointments several days can be difficult. So I was just curious if there was a consolidated version, I guess.
Well, I also will add too that every psychologist and neuropsychologist kind of has their own take with how they kind of do assessments. I know there are some that will do more just questionnaires and interview and diagnose autism. But I also know that the gold standard is to get multiple collaterals, do a clinical interview, and actually do the ADOS, which is a pretty extensive test. So I'm not saying, you know, that to do, you know, assessment always looks the way that we described, but it's the way that we feel like is the best practice.
Thank you.
Yeah, and to that point, I know that answers a question in the chat as well about high functioning autism. The ADOS is the gold standard for autism currently, and the way it's scored can actually help differentiate, you know, severity or level of impairment for autism. So again, that's specific to how we are conducting things at UT, but definitely trying to be as comprehensive as possible.
We have another question. What can projective tests show regarding treatment treatment objectives? So what can projective show regarding treatment objectives?
Candace, you want me to take that one?
Yeah, feel free, because I do not do a lot of projective testing, so I wouldn't be the one to answer.
I know neither Candace nor myself do a lot of projective testing. However, it might show some personality traits, or again, traits. This isn't a personality disorder, but some considerations that might be helpful in treatment, such as defensiveness or resistance, if they're more withdrawn or more outgoing, kind of more of these broadband characterizations that could be helpful in thinking of how treatment might best fit for them. Dr. Schmidt, do you have anything you'd add to that?
No, I think you covered that well, Morgan. When I first got started in the late 90s, it was probably a greater emphasis on including projectives in a full assessment. I think the field has generally moved a little bit away from projectives, but I still find them valuable. I don't use them very often. I'm usually doing larger neuropsychological evaluations, and adding one more large projective test is often a lot for the patient to undergo. But like Morgan said, it gives you a general picture of how that person responds to their environment. The old Rorschach, if scored properly and used properly, is still very helpful. And with children, there are still some projectives that are useful with children, especially as icebreakers for getting them involved in psychotherapy or group, or working with people who are trying to assist them in school activities or academic programs. Okay.
Excellent. Any other questions? All right. Well, I want to remind you that we do have our next CME session coming up on the 25th of April, and that will be a panel presentation on recognizing and reporting child abuse. This will be a session that we are not recording. So if you'd like to participate and hear what we have going on, we encourage you to put that on your calendar right now. Invitations will be going out very shortly, and that will be a CME credit. And we encourage you to share that opportunity with others. We do have an excellent panel joining us. Dr. Schmidt and ladies, I don't know how to say thank you enough for doing this for us today. Candace and Morgan, we are excited about your future in this field. You're extremely knowledgeable already, and we are so pleased to be able to have learned more today from you. Thank you so much. Thank you all for joining us, and we look forward to serving you through the CPAN program. Have a fantastic day.
Thank you so much. We appreciate the opportunity.
Thank you.